going to start with the second portion of the cardiology. So starting from the atrial fibrillation. Okay, so in the atrial fibrillation, here you can see at the ECG over here, there is irregular RR interval, okay, and there is no PV over there. So you can see clearly over here that the P is missing, okay, and there is irregular R, okay, and the pulse, if you feel the pulse of this patient, that's gonna be irregular. So any of the tachyarrhythmias, okay, if it is unstable, means the patient is hemodynamically unstable, you need to cardiovert. Okay, you need to cardiovert the patient. Okay, the difference between the cardioversion, okay, and the defibrillation is, okay, that for ventricular fibrillation and the pulseless VT, we use the term defibrillation, while for the others, we use the cardioversion, because this AFib, okay, this is a rhythm. So you need to cardiovert this rhythm into the normal one. In the ventricular fibrillation, there's no rhythm. So you need to defibrillate the patient. So if this atrial fibrillation, that is unstable, the patient is colchicine, patient is having chest pain, patient is having the hypotension, patient is feeling like dizzy, you need to cardiovert, electrical cardioversion, and that will be synchronized. Okay, because wherever there is a QRS complex, okay, you need to do a synchronized cardioversion. By synchronized, I means that, okay, your device that is going to deliver a shock, okay, at QRS. This is a synchronized. Otherwise, if you are not going to press a synchronized button, it can deliver a shock over here, okay, just after the QRS, when it's in a relative refractory period, and a VT may start, and that can go into VFib. That's why where the R is over there, you need to go for the synchronized cardioversion. And this is for the unstable patient. For the stable patients, well, AFib, it's a little tricky, but I'm going to confine it up to your level. Okay, I'm not going to go into the details of that one. If the patient is stable, is presenting in less than 48 hours to you, the onset of AFib is less than 48 hours, you are sure, then you can either electrically cardiovert that patient, or you can chemically cardiovert that patient with the myodron. Okay, or you could, this is for the, if the patient is presenting to you with a less than 48 hours. If a patient is presenting to you with greater than 48 hours, okay, then you can control the rate, you can electively cardiovert the patient, okay, after the 4 weeks of giving him or her the anticoagulants. Okay, AFib is not simple, by the way, okay, but I'm trying to make it as simple as I could. So if a patient is hemodynamically unstable, just synchronized DC cardioversion. If it's AFib over there, patient is presenting in less than 48 hours, okay, and you are sure that it's a new onset AFib, you can go for electrical or chemical cardioversion. Electrical is preferable as compared to the chemical. And if it's older than 48 hours, okay, then you can go for electric cardioversion. You need to anticoagulate the patient for 4 weeks, and then you can go for electrical cardioversion. Or you can go for, meanwhile, for the rate control strategy, okay? But new papers, they say that the rate control and the rhythm control, okay, they are equivalent, okay? So rate control, you use the beta blockers, they use the verapamil as well. For the rhythm, myodron and flecainide. If the patient is having a structural heart disease, then go for the myodron, okay, for chemical cardioversion. Otherwise, you can use flecainide as well. And any of the patients who is presenting to you with atrial fibrillation, you need to calculate a Chadwick score, okay? And if that score is 1 in male or 2 in female, you need to start these patients on lifelong anticoagulants. That is 1 in male and 2 in female, okay? 1 or greater than 1 and 2 and greater than 2 in female. You need to start these patients on the anticoagulants. You need to look Google this Chadwick score and look that one. Above the Chadwick score, we apply the Hasbled score, and in the UK, they apply the Orbit bleeding score to determine that giving the anticoagulants to this patient, either it's low risk, medium risk, or high risk. Okay, then you need to modify a dose a little bit, but that's beyond your level. Just remember, okay, the Chadwick score, and you're going for the direct oral anticoagulants. Okay, nowadays no warfarin, okay, no colchicine, don't go for that. That is rivaroxaban, and apixaban, endoxaban, and certain other products. When to give the warfarin in atrial fibrillation? When there is a valvular AFib, okay, there is a valvular AFib, go for warfarin. For the valvular AFib, we give the warfarin. All the other AFibs, we apply the Chadwick score, okay, and if it's 1 for male or 2 for female, we go for the docs. That's rivaroxaban, apixaban, and endoxaban, any one of them. Riva and Pixa are a better option. But if the valve is involved, okay, it says that, okay, it's MR3 plus, and there's atrial fibrillation, then you need to go for warfarin. Yeah, here are some direct oral anticoagulants: dabigatran, apixaban, endoxaban, rivaroxaban. So in valvular AFib, go for warfarin, and all the other AFib go for docs. The patient with atrial fibrillation, they mostly present with the palpitation and the tiredness. That is the complaint. Tiredness. That is the number one complaint. And then palpitations. When you're going to see at the ECG, there will be irregular R, and there will be no P wave. So if the patient is unstable, go for the DC cardioversion immediate, synchronized DC cardioversion. And if not, then you can go for like less than 48 hours or if it's greater than 48 hours. The other things that do support that you need to go for the rate control strategy or the rhythm control strategy is that if a patient is old, okay, we go for the rate control. And if the patient is having a previous ischemic heart disease, we go for rate control strategy. In comparison to that, if a patient is young, if the patient is in cardiogenic shock, these things, a new onset that's less than 48 hours, these things, they favor the rhythm control strategy rather than rate control strategy. Now comes the atrial flutter. The difference between the atrial flutter and fibrillation is when you look at the ECG, you can see that the RR are regular. Okay, it's RR is regular, and you can see that here you can see sawtooth waves. Okay, sawtooth appearance. Okay, that's a typical ECG of the atrial flutter. So treatment is same as AFib. The thing is that if you're going to electrically cardio the AFib, it requires little energy as compared to the atrial fibrillation. Atrial flutter requires less energy as compared to the atrial fibrillation. Now, very important, supraventricular tachycardia, okay, SVT. So here's an ECG of SVT. You can see that the heart rate is around like 160, okay, and now the heart rate is so fast that the P and T, they come close to each other, that they are superimposed, okay, giving the impression of a single wave. Now you cannot recognize that it's either P or T because they have submerged. So these P and T, they are superimposed. Okay, so SVT. The causes of SVT are like stress, okay, starting from the benign things, smoking, okay, pregnancy. Then there are like some serious causes as well, like ischemia, okay. Then it could be electrolyte imbalance, patient with the CKD. So it could be as simple as something, it could be something serious, and sometimes it is idiopathic, okay. This is a typical ECG of SVT. So you can see that heart rate is greater than 150, R to R, it's regular, okay. And P and T are superimposed on each other, giving an impression of 1. If you can recognize a P in an ECG and a T separately, it is not an SVT, okay. For the SVT, P and T should be superimposed. The heart rate is so fast that they are just forming a one wave. That's either P or T. You cannot appreciate this one. Okay, this is very important. When the patient with the supraventricular tachycardia is coming to you, the first thing you need to do is vagal maneuvers, carotid massage, Valsalva. The carotid massage, do it on one side, okay? Don't do it on two sides simultaneously. In the old people, you need to take care of them because they have erythematous plaques in the carotid, and you're gonna massage that one, and that's gonna go above and kind of is going to cause a stroke. So you always need to listen for a carotid bruit over here in an old patient. And if it's there, avoid that one. Listen to the other side. If it's over there as well, avoid that one. Then go for Valsalva or other maneuvers, the wiggle maneuvers. But in a young patient, yeah, the first thing you need to choose over here is Valsalva maneuver. Don't go for adenosine. Then comes the drug that is exclusively for the SVT, that is adenosine. The adenosine, the half-life of it is 15 to 17 seconds. You give it in the vein, okay, and you rush 20 ml of normal saline. After that, because it's having a half-life, you need to like circulate it quickly, and you lift the arm. The only contraindication is the asthma. You need not to give this one in asthmatic patient. In asthmatic patient, you have the other choices. Beta blocker is again contraindicated in patient with asthma. Then you go for the calcium channel blocker, non-dihydropyridine, that is verapamil. Okay, so first of all, vagal maneuvers. Don't go for anything else. What you're gonna do? No adenosine before the vagal maneuvers. First vagal maneuvers, then go for adenosine 6 mg IV rapidly, then 12, and then 18. Previously, it was 12, 6, 12, 12. So you need not to confuse yourself. Now it is 6, 12, 18. Okay, if still not, then you can go for either a beta blocker or a verapamil. Okay, you can try that one. If still not, then DC cardio version. DC synchronized cardio version, because that is an R-wave, you can see QRS complex over here with the 50 joule shock. Okay, you're going to give it. You're going to sedate the patient and you're going to give a 50 joule shock, DC synchronized cardio version. If the patient is hemodynamically unstable, then directly any of the tachyarrhythmias, if it's hemodynamically unstable, go for the shock. Go for the shock. So this is as far as SVT is concerned, very important SVT. Okay, you need to remember Valsalva first, then adenosine. Okay, ruling out the asthma. If asthma is there, beta blockers are also contraindicated. Then you need to go for verapamil. If adenosine you have given it's now working in a full dose, then you can choose either beta blocker or verapamil. Either of them. You cannot combine the beta blocker and the verapamil together. Okay, you have to choose either of them. And if not, then go for the DC cardio version. Now, its Torsades D point is, okay, that's a polymorphic VT. This means that twisting around the point, okay, Torsades D point is, if I could draw this thing, it's like this. Okay, it's a polymorphic ventricular tachycardia. Okay, QT prolongation is the cause, okay, and it can go into the VFib. That's a problem. So causes of long QT, electrolyte abnormalities, all the causes of like long QT, okay, the long QT can go into like the VT and then to the VFib. For causes of the long QT, we're going to discuss this later on, okay. So this is around twisting around the points, and for the Torsades D, monomorphic VT will be like this, okay, and the polymorphic VT is gonna be like this. Okay, twisting around the points. Okay, so IV magnesium sulfate, that is a treatment for Torsades D point. Now comes the ventricular tachycardia. That is a monomorphic ventricular tachycardia. Torsades D point is for the polymorphic ventricular tachycardia. So you have in VT, you have wide QRS complex. Okay, wide QRS complex, and you cannot really appreciate between where the QRS is. Okay, this is the thing that favors the VT, broad QRS complex, and you cannot appreciate where the QRS is. There are the other points as well, but you need not to remember. That's not up to your level. You're going to confuse yourself. So just remember this pattern. Okay, if it's unstable, like you need to cardio it. Okay, if you remember, I said that VFib and the pulseless VT, they need defibrillation. Okay, if the choice is over there that if a patient's coming to you with this pattern and it's pulseless, what we need to do, cardioversion, defibrillation, and the drugs are given below. You need to go for the defibrillation. Do not say that it's a cardioversion. For the pulseless VT and VFib, go for the defibrillation. It's with the same device. You give the shock, but you call the defibrillation. This you call the defibrillation. Okay, here you cannot appreciate a QRS complex. Okay, so patient's having no pulse. If the patient is having a pulse and is unstable, okay, that means the BP is low, is cold calming, then you need to go for cardioversion. For defibrillation, you use the term only for the VFib and the pulseless VD. Okay, if it's stable, then you can go for the amiodarone. Always choose amiodarone. That is preferred. Amiodarone. Other things, you can go for the flecainide as well as lidocaine. But always in the VT, if it's stable and you feel a pulse, definitely you feel a pulse, that's going to be stable. Not necessarily. If the BP is low, still you will be having the pulse. So you need to go for amiodarone in the patient who is having a VT, okay, but the pulse is there. Now comes the ventricular fibrillation, where you do not have any rhythm, nothing. You are not ventricular fibrillation. The patient is coming to you in a collapsed state, no BP, no pulse, because the atrial ventricles are fibrillating. How could there be a pulse or a BP? Okay, so ventricular fibrillation, directly you need to defibrillate the patient. Okay, you need to defibrillate the patient. Now, sometimes the scenario comes like this. The patient is over there, okay, and you felt there's no pulse, there's no BP. What immediately you are going to do in this patient? That is CPR. Start the CPR in this patient. And as soon as the pads are available, or you need to attach the patient to the monitor, check the rhythm and go for defibrillation. So here, if the CPR is given and the patient is somewhere outside, okay, when you are going to connect the pads, only then you're going to get the rhythm and you will find that it is V-fibrillation, ventricular fibrillation. Otherwise, how are you going to get to know? So start the CPR in this patient. Start the CPR immediately. As soon as the pads are available, just attach them and just shock the patient and follow the ACLS protocol. So there is no QRS. You cannot get anything. No BP, no pulse, nothing. So a 49-year-old semi-conscious with the BP 8060 ECG shows broad complex tachycardia. Okay, which is the most appropriate action. As he is hemodynamically unstable, this depends on the pulse. If the pulse cardiovert, if the pulse is there, this could never be ventricular fibrillation. There's no pulse. Okay, if there's no pulse, that could be pulseless VT or ventricular fibrillation. Okay, only you get to know when you're gonna attach, okay, the rhythm monitor. So if no pulse, just defibrillate, unsynchronized. This is unsynchronized. Otherwise, it is synchronized cardiovert. Defibrillation is always unsynchronized. Oh yeah, it's writing over here. The ventricular fibrillation never has a pulse. No BP, no pulse. Now comes the Wolff-Parkinson-White syndrome. Normally, what happens that if you try to understand this one, here is your SA node and here is your AV node. So SA node sends through the bundles, okay, that is backband bundle that's going to the left atrium, interior, middle, and posterior to the atrium as well as to the AV node, and then AV node to the bundle of his right bundle branch, left bundle branch it. This is how the normal electrical circuit of your heart is, okay. But say, for example, that the SA node, it is sending an impulse over here through its bundle to the left atrium or the right atrium, and here there is a pathway, okay, accessory pathway, which is conducting this pulse to the ventricles. Normally, it should be the ventricles should receive a pulse through the AV node, but here there was a extra bundle, that is what we call bundle of Kent. So now it's receiving the pulse like this through this bundle. Okay, this is called the bundle of Kent. It could be either right side, it could be either on a right side or either on the left side. Okay, so this is called the Wolff-Parkinson-White syndrome. Okay, in these patients, what's there? There's a short PR interval because now the pulse, actually the current should go through the AV node. Okay, and AV node, you know that it holds the current for a moment in order for the atria to contract first and then the ventricles. But here it has now waited. Okay, it has gone through this accessory pathway. Okay, now there will be the short PR interval, and there is a slurring of QRS that we call the delta wave. This initial slurring, this one, and there will be the short PR interval. Okay, and there will be the wide QRS complex. This is as far as the Wolff-Parkinson-White syndrome is concerned. It's important, by the way. Short PR, delta wave is present, and let me show you. This initial slurring of QRS complex, okay, because this is formed because the ventricles are depolarized earlier through this bundle. Okay, so there is the initial slurring, and there is short PR interval because this has gone through this accessory pathway, and there is a wide QRS. These are the three features of Wolff-Parkinson-White syndrome. A 12-year-old child presents with a sudden onset of palpitation difficulty while running at the school track. 30 minutes after the 30 minutes, the symptoms resolved. ECG shows pre-excitation. Pre-excitation is this delta wave that is coming. Okay, this delta wave. Let me show you if I can make it over here. This initial slurring. Okay, that is the delta wave. And prolonged QRS. What is likely diagnosis? That's Wolff-Parkinson-White syndrome. Simple as that. So it has type A and the type B. Well, I think if it's coming over there, no, you need not to go for the type A and type B. So what is the definitive treatment for Wolff-Parkinson-White syndrome? Radiofrequency ablation of this accessory pathway. This accessory pathway that is between the atria and the ventricles. Normally, atria and ventricle have connection to the AV node and nothing else. But there is a connection. Say, for example, it's on the right side here. So you need to ablate that one through radiofrequency ablation. Type A and the type B with Parkinson-White syndrome. Okay, type A is left-sided, type B is right-sided pathway. Okay, this is what you need to remember. Okay, now broad complex tachycardia could be VT, VF. There is no QRS. No, do not confuse this. By the way, if you look at over here, do not confuse the VF with Torsades D points. That's different. VFib is different. Okay, totally different. VFib, no pulse, no BP, and there is no actually the QRS. Torsades D points, it's gonna be having some regular thing over here, like, okay, this one, then the small and this. Okay, this is irregular. VFib is irregular. Okay, cannot get that one. What's going on? SVT, need to remember typical ECG. AFib, irregular or no P waves. This is the same which I have already told you. Okay, you need to look at the ECG, okay, of the tachycardia patient, whether it's a narrow complex QRS or it's wide complex QRS. If it's narrow complex and the tachycardia is, it could be SVT where there is a regular RR and there is no P and T, you cannot differentiate. That is SVT. In the AFib, RR will be irregular and there will be no P wave. In atrial flutter, RR will be regular and there will be sawtooth appearance. Now come to the QRS wide. If the QRS is wide, okay, if it's QRS is wide, there could be like so many things over there. It could be VT, polymorphic VT, or Torsades D pointage, or monomorphic VT. So you can have an idea by looking at the QRS complex. Yeah. Now comes the hypokalemia and the hyperkalemia. So hypokalemia is when your potassium is less than 3.5, and if it's greater than 5.5, it is hyperkalemia. Now, let me tell you a very beautiful thing over here. ECG, that is important of the hyperkalemia or hypokalemia. What's going to happen? One thing you people know, that is hyperkalemia and it is hypokalemia, okay? One thing you people know is that in hyperkalemia, there will be tall T waves. Okay. Okay, let me start from P, QRS, ST, and T wave. Okay, this is how the ECG is. Okay. In hyperkalemia, you know, there are the tall T waves. Okay, tall T waves. Hyperkalemia. Okay, this is how you're going to remember. Okay, the P wave will be exactly opposite, the flat T wave, flat P wave in hyperkalemia. And now if you go to the hyperkalemia, the P will be large and the T will be flat. Making sense? And In hyperkalemia, there will be the ST elevation. In severe hyperkalemia. In hyperkalemia, there will be the ST depression. And the QRS complex is wide in both of them, or they could be narrow. This is how you're going to remember hyperkalemia, the hypokalemia, based on the ECG finding. Okay, let's go for the hypokalemia. Hypokalemia is like you have the vomiting and the diarrhea, okay, particularly diarrhea, okay, you're losing the potassium. Then like loop diuretics, furosemide, okay, that's going to cause hypokalemia, hyperaldosteronism, Cushing, proximal linear tubular acidosis, okay, type 1, type 2, they causes the hypokalemia, while type 3, there is hyperkalemia, magnesium deficiency. And the insulin that causes the potassium to shift into the cell, metabolic acidosis, hypokalemia. So you have broad flat T waves, ST depression, and QT prolongation, what I have already told you. In the hyperkalemia, if it's greater than 5.5, this is acidosis, or if you are giving the spironolactone or AC inhibitors, they also cause hyperkalemia. CKD patient, they have the hyperkalemia. Okay. So what you do for the hypokalemia, you definitely the potassium, and you go for the ECG if there are the ECG changes or not. Okay, for the hyperkalemia, if it's mild 5.5 to 5.9, it's moderate 6.0 to 6.4, and greater than 6.5 is severe. Now, if it's mild, okay, and there are no ECG changes, you need not to do anything. Okay, you need to repeat the level and correct that why it is going on. If the patient is receiving any kind of medication that is causing the hyperkalemia, okay, and if it's moderate, you need to go for ECG. If there are the ECG changes over there, okay, then you need to give the patient a calcium gluconate, that is a membrane stabilizing agent, because these patients, they are prone to develop the ventricular arrhythmias, okay, ventricular VTs and VFib, the patient who are having this hyperkalemia. So if there are the ECG changes as moderate or severe hyperkalemia, you need to give the patient 3 things. That is, you need to nebulize with the Ventolin, okay, you give the patient calcium gluconate, okay, 10 ml of 10% calcium gluconate over 5 to 10 minutes. That is a membrane stabilizing agent. And the third thing, you're going to give the insulin dextrose infusion, because that's going to shift the potassium into the cell. The 3 things you need to give. Okay, so calcium gluconate, that's not going to lower your potassium. Insulin and Ventolin is going to lower your potassium in your blood. Okay, but calcium gluconate, as insulin takes time to act, so calcium gluconate, it is a membrane stabilizing agent. So this is what I have already told you, calcium gluconate, and you are giving for IV insulin. Okay, so this can go into the ventricular fibrillation, and VT is now coming to the acute coronary syndrome, ACS. What comes under ACS? There are the 2 things, okay, either it's NSTEMI and unstable angina, or it's STEMI. In unstable angina and in the NSTEMI, there will be the ST depression, okay. The difference between the NSTEMI and the MI, okay, and NSTEMI and unstable angina is that in NSTEMI, there will be the TROP positive, okay, cardiac markers will be positive, while in unstable angina, they will be negative. And in the STEMI, there's ST elevation. When there's a STEMI, you need not to go for the troponin. You need to act promptly, either for the thrombolysis or percutaneous coronary intervention, that is a PCI. Okay, so unstable angina and STEMI, they are in one side, they are on one side, and STEMI is on the other side. The real difference between the 2 is actually the troponin. If the trop is positive, it's STEMI. If it's not, that's unstable angina. So a patient is presenting to you with, okay, let's deal with this STEMI. Generally, if the patient is coming to you, okay, with a chest pain, what you need to look for? You need to look for the risk factors first, okay, and then the history of the patient. The risk factors are diabetes, hypertension, okay, hypercholesterolemia, and smoking, and a family history. These are the 5 things. And then you need to look for the chest pain as well, okay, whether it is, okay, it has a radiation, it is like it's moderately severe or severe in nature. With that diaphoresis, with the SOB, it is related, okay. If these things are there, okay, then you're going to count that where you actually fall and what you need to do over here. And definitely you need to get an ECG where you could find either an ST MI, okay, or that's ST elevation or ST depression, okay. So first, dealing with the STEMI, okay, that's the most serious thing of all of them. So STEMI, the patient is presenting with, maybe he's having a risk factor and he's presenting with the chest pain, okay. The chest pain of the MI, okay, that is never pinpoint. That will be diffuse, that will be pressing, sometimes dull as well. There will be the radiation, diaphoresis, or the SOB related to that one, okay. And you need to go for the ECG, okay. But everyone can go for the ECG, but before the ECG, you should be having something in your mind that, okay, what you are trying to expect. So that's your history, risk factors, and the patient pain, okay. That's gonna guide you, okay, that what you could expect on the ECG. So STEMI, you can see that there are like ST elevations in 2-3 AVF inferior leads, okay. 1 mm of elevation in all the leads except V2 and V3, where you exactly need like 2 mm of elevation, because in the male who are greater than 40 years old, 2 mm of elevation. If they are less than 40 years old, 2.5 mm of elevation in these 2 leads, V2 and V3. And if the females are there, there's 1.5 mm of elevation. But generally, remember, 1 mm of elevation, okay, in 2 contiguous leads, okay. And whenever you look at the ECG, okay, you do not see it randomly, that you are seeing the 1 and you are then seeing the 2 and you are then seeing the 3 and then the V1. No, okay, you need to look, okay, where is like that you need to look that on the specific leads. Like if you start looking at 2, that's an inferior, so you need to look the inferior leads with that one. 2-3 AVF, whenever you have started looking 2-3 AVF, okay, V1, V2, V3, V4, 1 AVL, V5, V6, you look at the ECG like this, okay, because these ECG, actually the electrodes, okay, like 2-3 AVF, they denote the inferior surface, and that's supplied by RCA, okay. There's a corresponding artery. V1, V2, V3, that's interior, so that corresponds to the LED, okay. And 1 AVL, V5, V6, that is left circumflex. So you look at, that's going to give you an idea, because the lateral wall MI, 1 AVL, V5, V6, they will be involved, okay. So you need to look in a certain pattern when you cannot randomly, you need not to randomly look at the ECG leads, like if you are looking at the 2 and then you are looking at the V2. No, when you have started looking at the inferior V2, 3 AVF, you need to look 3 simultaneously, okay, and then you can go to someone. It's not simple like this, but as your level is concerned, okay, keep this in your mind, okay. The 2-3 AVF, that's inferior wall, okay, and RCA, 80% is RCA and 20% circ, okay. And it's an interior wall MI, V1 to V4 even, that's interior septal wall MI, okay. LED is 1 AVL, V5, V6, that's lateral wall. So it's not as simple as he's telling you, but like generally you need to remember it up to now, okay. That's going to solve your questions, and you'll be able to give the answer. Now, there's also a posterior wall MI, where actually in V1 and V2, there will be the R wave, and there will be ST depression, posterior wall, okay. There could be the circ or RCA, okay, and you need to apply it. Then if you are getting, normally there is no R wave in V1, but if there is R wave like prominent and ST depression, the patient is coming to you with the chest pain, you need to get the posterior leads. That will be V7, V8, and V9, and that's going to give you elevation over there if it's a posterior wall MR. Now, what you do for the STEMI in a patient, okay, you give the ACS protocol, that is 300 mg of the aspirin and 300 to 600 mg of the clopidogrel, and now and the morphine with the nitrate, can go for the Oxygen, it's not necessary. If the patient doesn't require oxygen, it's okay. Don't give the oxygen. Now, in the STEMI, you need to act promptly. Either you're going to go for the PCI or the thrombolysis. Okay. If you have a PCI facility available, okay, go for the PCI. That is the gold standard. Okay. And if there's no PCI, then you can go for thrombolysis. Now, you have heard of this concept, 120 minutes. If the patient is within 20 minutes, you can go for the PCI. If not, then go for thrombolysis. Either streptokinase, like most of the Eastern countries they are using because it's cheap. Otherwise, tenecteplase and the LTplase, okay, that is actually a better agent as compared to the streptokinase. But that's a little expensive. Now, the concept of this 120 minutes, what that is. Say, for example, this is for, like, say, for example, I'm working in a hospital where there is no PCI available, but there is a thrombolysis. And the patients come to me with a chest pain, okay, and I think that it's STEMI, like looking at the ECG, but for sure that's STEMI. Now, I'm like, PCI is superior to thrombolysis, but I'm thinking that, okay, the nearest hospital, if they're going to take it to the hospital, that's 3 hours away. 3 hours away, okay, from my hospital. So it is actually it's more than 120 minutes, okay? In these 3 hours, he's going to lose his myocardium. So I will go for the thrombolysis. Okay, this is the 120-minute concept. Okay, that if you are working somewhere and there is no thrombolysis and you have to shift the patient, at that time, no facility of PCI is available. And if you're going to send the patient for PCI, if you're going to call some interventionist, that's going to take more than 120 minutes. So you need to save the myocardium. Go for the thrombolysis rather than PCI. If the PCI is available, that is a gold standard. If you are given that a patient is coming with the STEMI, okay, what you would choose, okay, blindly if it's given to you, go for the PCI rather than this thing. Okay, so long term, these you need to put the patient these on antiplatelets. Okay,